I'm talking about celiac disease and type 1 diabetes. As you can see here, these are two conditions that we frequently think about as going hand in hand, and I think we have a good understanding about this, but I think there's a lot of work we still need to do, and I'll share with you some insights into that. All of you in the audience today will be very familiar with Samuel G's original description of what is now celiac disease. This description is over 130 years old. What may surprise you is that this association between celiac disease and diabetes actually goes back quite a long time as well. Go on, shout out, who's that guy in the bottom left-hand corner there? Roger Bannister. Okay, so he broke the 4-minute mile, but does anyone else know why he's in this room today, what else he did? Or what he later became after his running career? He was, yeah. So he was an academic neurologist, and we're privileged to have an academic neurologist following me this afternoon. But in the year 1954, we see the first description of celiac disease and diabetes. So my talk, I'm going to focus on 5 things, if I may. I'd like to talk to you about the prevalence of celiac disease in type 1 diabetes and vice versa. I'm then going to fly over genetics, because it's something I'm not really very good at, but I will give you some insights into the overlap between these two conditions. We're then going to talk about dietary adherence, the challenges that we face and people with celiac disease and diabetes have in adhering to diets and the consequences of that. And this leads in nicely to screening. This is a very controversial area. When should we be screening? How frequently should we do it? What is the evidence base? I'll be showing you some insights into that. And the talk is on type 1, but some of you may be aware in the recent weeks there's been concerns about type 2, and we're going to discuss that as well, if I may. So, we talked about the Finns earlier on and their elegant work in celiac disease. This was a lovely paper in 2007. What it shows here, like a lot of other autoimmune diseases, both celiac disease and type 1 diabetes are on the rise. So they've mapped their populations and seen the increasing prevalence over time. In the UK, we've done a series of population studies demonstrating that prevalence in the UK is 1%. The difficulty you have, and all of you aware, is we're not detecting all these patients. Diabetes. Diabetes, 6% of the UK population, and I suspect that's probably reflective of most of the Western societies. But to emphasise, the big epidemic is type 2 diabetes, okay? So 0.6% of our population from Public Health England have type 1 diabetes. So these things go hand in hand, okay? This is a lovely piece of work, meta-analysis, systematic review by Jonas Ludvigsson and colleagues. And it highlights all the work that's been done over the past couple of decades looking at the prevalence of celiac disease and type 1 diabetes. There's a couple of things here that I'd like you to keep your eyes on. These are international studies, okay? A mixture of paediatric and adult populations. And for the best part, diagnosis of celiac disease is based on villus-Ashfield antibodies. But there are a few here where the diagnosis has been done by other ways. So in 26,000 patients with type 1 diabetes, the prevalence from this meta-analysis of celiac disease is 6%. Keep that figure in your head, 1% celiac disease in the population, 0.6% type 1 diabetes. There's clearly an association here. But what is really interesting by teasing out this data is there is a difference between the paediatric population and the adult population, and that has relevance to our screening practices, I believe. So it's lower in adults, 2.7%, and children, 6.2%. Other way around. So we're looking at celiac disease in type 1 diabetes. What is the prevalence of type 1 diabetes in patients with celiac disease? These are the questions that patients will be asking us. This way around, there's actually been a paucity of studies looking at that association. And this is one recent one by, again, the Finnish group looking at this. And I think this is interesting. Patients with celiac disease have a higher risk, particularly men, young men between 30 and 64, of having type 1 diabetes compared to population controls. It doesn't seem to be there for type 2 diabetes, but there is something there. And this has been replicated in the paediatric population. So Jonas Ludvigsson's group, looking at their Swedish cohort, hazard ratio is 2.4. So there's an increased risk of having type 1 diabetes in celiac disease. So that's the prevalence, okay? There definitely is an association there. The genetics of all this, well, this gets a bit complicated. We recognise that there is an association with DQ2 and DQ8, the ones we talk about in celiac disease, but the genome-wide association studies suggest that there's more than just HLA typing that's influencing it. If you're interested in this, there's a lovely review article here in Coeliac Diabetes highlighting the genetics and what other factors may be contributing to this outcome, and environment and immune response. And I'm going to point you and signpost you in that direction if that's what you would like to know more about. But I want to come on to diets, because that's really central to celiac disease. It's the only treatment we have, and it's also important in diabetes. In celiac disease, there is only one established treatment, and these are the benefits of being on a gluten-free diet for people with celiac disease. The truth of the matter is, and we see it in our everyday practice, is that although it's perceived to be a very easy diet to adhere to, it is actually very challenging. And in this review here highlights that it's an international problem, people struggle, and strict adherence ranges between 40 and 92%, depending how you assess adherence. And we've heard more about assessing adherence this morning. So the challenges are there for people just with celiac disease. Add type 1 diabetes into the equation. Well, I'm going to refer to this. This is the NICE document about type 1 diabetes. I have to say, I wasn't so familiar with this, and I've been talking about glycemic indexes for a period of time, but NICE, and dietitians, you'll be far more familiar with this in context of DAPHNE regimes, is that we're on carbohydrate counting, okay? And clearly that has influences in relation to the gluten-free foods that you have. Insulin is the mainstay of treatment for diabetics, but clearly diet is an important component as well. Put the two together, what's the research? Well, actually, there's not so much research about the practicalities and the challenges of being on two restrictive diets, let's say. The studies that have been done, small studies, suggest that adherence rates are lower, but I would like to see some higher quality studies done in this area just to see those challenges. If the challenges are recognised, what are the consequences? That's what we need to know for our patients. So this is one of my predecessors, John Leeds in Sheffield. He did his MD looking at celiac disease and type 1 diabetes. John camped out in diabetes clinics, managed to recruit 1,000 patients. He'd screen them all for celiac disease. They all proceeded to have biopsies. And in that cohort of adult patients with diabetes, there was a prevalence of celiac disease of 3.3%. Okay, so that's near where the figures were in that meta-analysis, 2.7. At diagnosis, these patients with concomitant celiac disease and diabetes, compared to diabetes load, had a poorer HbA1c. Okay? So that's important at the point of diagnosis. What about their long-term consequences? If they're going to have concomitant disease, are they at higher risk of getting ketoacidosis, hyperglycemic episodes? Well, some work that we did with Jonas on their Swedish cohort suggests no. Okay? So it doesn't seem to influence their diabetic glycemic control in the long term. But it's more than just glucose control. In celiac disease, we talk about the complications. We talk about bone disease. We talk about autoimmune diseases. We talk about the microvascular diseases. As Dan mentioned earlier on, a lot of this work has come from the Swedish cohort to give us insights into this. But there are other groups. Our group has looked at this on microvascular complications. There's a group in Germany that looked at bone health. That's quite messy as a slide, and I just want to give you one take-home slide that kind of summarises the data that's out there at the moment. So for HbA1c, I've shown you John Leeds' work. That's prospective. The previous studies by the Dutch group and the Finnish group was a retrospective study, so there may be some debate, but the HbA1c seems to be influenced. But for nephropathy, retinopathy, quality of life, having concomitant disease of type 1 diabetes alongside your celiac disease increases your risk of developing these complications. So we are in a bit of a mess. You all are aware about our long-term follow-up, but hopefully I'm showing you that in the context of diagnosing these people, in context of their complications, that maybe we need to be having more intensive review potentially of these individuals. So that brings us to screening. If they've got an increased risk of complications, then surely we need to be screening for this condition. It fits a lot of WHO criteria for screening. It's difficult to diagnose. It's common. We have easily accessible screening tests in the context of doing serological tests. What is difficult is to date we have no sort of cost-effective analysis to what is the most best way of doing it. And although a lot of you in the audience will disagree about an asymptomatic celiac disease patient, there are people who describe no symptoms, and through screening, picking them up, are we doing them harm by putting them on a gluten-free diet? And that is currently being addressed in a study called the CD Diet Study. So we refer to guidance, okay, when we don't know. It's a mess. These are the guidelines that are out there about screening in celiac populations and diabetic populations. As a take-home, I would say we need to be screening everyone at baseline. That's an important thing. But thereafter, up for debate. That's adults, okay? A lot of you are paediatricians, work in the paediatric practice. Well, this is some important work. So SBGAN have their guidelines, and in adult practice, we've raised concerns about some of this. But one of the suggestions was in there is that we should be screening these patients with TTG alongside checking their HLA. And that, Peter Gillett's group in Scotland, alongside work from Holland, have actually raised some concerns about that because they share a lot of common HLAs. And in their group, screening through HLA didn't actually discriminate or rule out patients who had celiac disease. So this wasn't in any way a cost-effective tool for screening. Now, I'm going to be showing my embarrassment. I wasn't aware of this study that was published last year in October at UEG, and it's a landmark piece of work that remains to be fully published, but it's fascinating. I'll just give you the take-home of this. This is, through screening, they managed to prevent type 1 diabetes in a Hungarian cohort, okay? So, these, again, Salzburg, names that you'll recognise in the field. They looked at school children, okay, born over 5 different years, and they targeted the middle year cohort, the age of 6. And they checked that cohort for celiac serology, identified, and I'll just take the next step and bring it up here, 4,278 patients who were screened, biopsied them, put them on a gluten-free diet. And the take-home from this is that they had a lower prevalence of type 1 diabetes. So through screening that cohort compared to the rest of the other 4 year groups, they had managed to remove type 1 diabetes. And previous work has suggested from that group that the TG2 is deposited in the pancreas, and that may influence our production of insulin. So that's interesting. It's not been fully published yet, but through screening, there may be real merits in actually preventing type 1 diabetes, so we'll wait to see that one. So, guidelines I've shown you, conflicting screening practices, where shall we go, okay? I don't know if I've given you any answers, but I hopefully showed you the way of celiac disease and research as a general thing. There are lots of unanswered questions. We need to try and define them better. Sord Bakker, who works in Holland with Chris Mulder's group, has written this paper, which is a very pragmatic approach, and I think this is entirely reasonable, and it's a strategy I would encourage. This is in adults, okay? I said to you, prevalence is higher in paediatrics, so it may be different, but I think it's entirely reasonable diagnosis to screen and then reassess again at 5 years for patients who are negative. And that is based on a systematic review that's recently been published, which suggests that was in children and adolescents that between 5 years or 2 yearly intervals, that may be the most appropriate strategy through tissue transglutaminase. So, I've showed you celiac disease and type 1 diabetes hand in hand. Type 2 diabetes, this is a divorce, okay? They're completely separate entities. They're not related in any way at all, are they? Well, that's what we always said. And this, how many people saw this? Hands up, saw this a couple of weeks ago. And mine, okay. So this blew up as a huge media storm, okay? I put the UK press on here, but this was international, okay? The Times, the Express, I think Sarah and I know how they bombarded us in February for something that we did about gluten-free prescriptions. You may remember this from last year. But this, just to summarise, is an abstract that was, so it's not a full paper, it was an abstract presented at this cardiology meeting in the beginning of March. And the suggestion, the headline is that if you're on a low gluten diet, you have a higher risk of type 2 diabetes. Now, sensationalized headlines, gluten-free diets, people with gluten sensitive, fad diets, you're potentially doing yourself harm, okay? Big media sensation, okay? I'm just going to give you the detail in this, and it's important so you can take it back to if people do ask. This was a large study, 200,000 patients, 200,000 people, not patients, 200,000 people, 3 separate cohorts, 2 of them were nursing, 1 was healthcare professionals. So this is a selected group of patients. It's not a population, they're selected groups of individuals, but big numbers, 200,000. They've been following them for a number of years, and they've been asking them to do food frequency questionnaires, and based on that, assessing their gluten consumption. So there's a couple of things that you'll see from the data, is their mean gluten consumption rate was about 5 to 7 grams of gluten. That is different to population studies done in Denmark and in Holland, where the general population's mean gluten consumption is about 12 grams. There's a slight difference there that may reflect the population that they've assessed. The second thing is it's food frequency questionnaires. Those of you who work as dietitians will know about the controversies about that and then extracting that to represent gluten. But what they've done is looked at low levels of gluten consumption versus high, and there is an association, okay, with low levels, so not gluten-free, that's the important thing, so just people who are taking lower levels. And the take-home, which I found out really fascinating, is this exact same group published on one of those cohorts, the nursing group, only about 6 years ago, and showed that they had those who were eating higher levels of French fries had a higher level of type 2 diabetes. They do look at fibre in this, but that cohort that they're using in that study had a higher level of French fries. So is it those people who have a lower gluten in their diet are actually eating more junk food? Okay, that could be it. It needs to be established, but that's just some insights into where we're going, and it's important to break things down. So that's where we are. Coeliac UK, just to say, did put a press announcement about that, just to emphasise this. It's important that we recognise that. So, ladies and gentlemen, that is a whistle-stop tour of type 1 diabetes and celiac disease. There's a lot we still need to know about these two conditions, but the relationship is there, and if we can prevent it in childhood, I think that's interesting and fascinating. The work in type 2 needs to be done. Thank you very much for your time. So, do I really want to invite questions onto myself? Okay. Yeah, happy to take any questions. I think it's one over there.
I have a question about your study your colleague did on the 1,000 diabetic patients with a biopsy and found 3% or 6%.
3% in our Sheffield cohort, of adults.
But then I understood that celiac disease is underdiagnosed in the normal community, so you compared it to 1% prevalence but that's, so if you biopsied 1,000 normal people without diabetes, is it possible that, that would go up anyway? So it might not be that different? Because you've got one population where you've got diabetics and you're biopsying them all, but you're comparing it to a national figure.
So I'll take it back. So they were 1,000 patients attending a diabetic clinic who were screened for celiac disease by having celiac serology. They weren't all biopsied. The ones who had positive serology then proceeded to have a biopsy. So they are serology positive patients, and of that, 1,000, 3.3%.
Okay.
Is that clear?
Do you find that you get worse compliance with the gluten-free diets in patients with type 1 diabetes? Do you find that the compliance is generally worse?
So anecdotally, I think we do. I think it is far more challenging. I think I'm very fortunate in Sheffield to have Nick as my colleague who will go through things like that. But you can imagine in general practice where you don't have often specialist dietitians, it can be challenging. But anecdotally, yes, is the answer.